Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content from an educational webinar titled Key COVID-19 Studies Influencing My Practice Following IDWeek 2022. During this podcast, Dr. Princy Kumar, Professor of Medicine and Microbiology and Senior Associate Dean of Students at Georgetown University School of Medicine, and Dr. Paul Sachs, Professor of Medicine at Rush University Medical Center, discuss new COVID-19 data, including vaccines, diagnostics, risk stratification, therapeutics, and long COVID. For more information about Dr. Kumar and Dr. Sachs, and for a link to the full online educational program, including downloadable slides, please visit the links in the show notes for this episode. Now, let's get started and hear what Dr. Kumar and Dr. Sachs have to say about new COVID-19 data from IDWeek 2022.
Thank you so much, and thanks to all of you for joining us. And we actually are going to move at a pretty brisk clip, so make sure you've had your coffee. Let's start with this study of an Omicron BA.1 bivalent booster. This is a Moderna vaccine. And you'll notice it's BA.1 bivalent booster. This is the original strain, the Wuhan strain, plus BA.1. And you'll note that it is not strictly a randomization. It's actually a period of time when people were randomized, and then a second period of time when people were treated with the original vaccine, and a second period where they got the Omicron booster. And the endpoints were safety, reactogenicity, and immunogenicity of this particular Omicron booster. And I want to emphasize that this is not the Omicron bivalent booster that's currently available right now by both Moderna and by Pfizer. So let's take a look here at the results. This is a tabular information of the results. It looks at first these side effects from it, and compared with the second dose of a primary series and the third dose of that vaccine, this bivalent booster was associated with similar or lower reactogenicity and lower systemic reactogenicity. And there has been at least some anecdotal evidence that people over time are getting less of the severe systemic reactions to their COVID vaccines, mRNA vaccines, and that does appear to be the case in this study. So what about immunogenicity? Well, immunogenicity is shown here, and you can see that this meets the criteria for superiority in the antibody titer. So the neutralizing antibody titers were higher using this Omicron bivalent booster. So it has original Wuhan strain plus bivalent BA.1, and it had higher titers. So therefore, the take-home points from this study, no new safety concerns. In fact, reactogenicity was the same or lower, and that bivalent boosters showed significantly higher antibody titers against BA.1 compared with the original mRNA vaccine. So these data actually were part of the reason why we went forward with the bivalent boosters now, even though we don't have comparable human data with the BA.4/5 bivalent boosters that are in clinical practice. Next topic, risk factors for severe COVID-19 breakthrough infections. This is a VA study with the presenting author, Weston Branch Elliman. I take a tiny bit of credit for Weston, who's a very brilliant clinical researcher here in Boston, because she rotated through our ID elective when she was a medical student. All right, risk factors for severe COVID-19 breakthrough. And here, it'd be great to know, since so many people now are vaccinated, what are the risk factors for really bad outcome? And so they looked at over 100,000 VA patients who received their primary vaccine and subsequently developed laboratory-confirmed COVID from December 2020 to February 2022. So this includes both the Delta period in the 2021, and it includes early Omicron era. And severe disease is hospitalized with receipt of supplemental oxygen, getting dexamethasone, ICU, etc., or they died. Exposures are looked at here in the multivariable analysis, and let's take a look at some results. Older age, are you surprised? Of course you're not surprised. This is always a risk factor for severe COVID-19. Yes, indeed. What I'm hopeful for, I'm just going to have a little parenthetical immunologic thought, is that the children who keep getting COVID are getting the kind of coronavirus immunity that we grew up with the old coronaviruses. And so this will no longer be a threat to them when they get older. But I can tell you, for older people, this virus is still a threat even after vaccination. Now you'll note booster dose have 50% lower chance of getting severe disease. Why is that important? It's an amazing thing, but there are people who have not gotten their third dose of the mRNA vaccines. The 2-dose strategy was chosen initially because they had some immune response data, and there was a big rush to get these out there. But 2 doses should not be considered fully vaccinated. It should be 3 doses. Okay, so the researchers, led by Weston Branch Elliman, took a look at these data and made this machine learning model that could predict the likelihood of severe disease. And one thing I think is fascinating is to look at the greater severity of Delta versus Omicron. What a difference. Anyway, big differences. So 8 features of predictive models: chronic kidney disease, dementia, heart failure, increased BMI, mobility impairments, as long as taking various medications. So I think what we can say from this study is the traditional risk factors for severe COVID-19 were likewise identified for severe breakthrough infections. They still are highly relevant, and that getting a booster vaccine attenuates the risk for severe infections. So clinicians out there, your patients who've gotten 2 vaccines, have them get their third. And if they have gotten 3 vaccines and it's been a long time since that third one, and especially if they haven't had COVID themselves, then have them get now a 4th. Okay? Anyway, that's at least, I think, an important message from this VA study, which I actually think is quite good and should be appearing in a publication near you soon. Okay, next study. SARS-CoV-2 viral load, assessed by digital droplet PCR, association with patient symptoms and outcome. Now, you probably have a sense that there's this literature out there on the association between the amount of virus a person has, their viral load, and how bad the disease is. But this is not something we can actually measure in any kind of patient-applied way. We have cycle threshold on our PCR, some of our PCRs, although you can't get it off a multiplex PCR platform generally. But this is a way, digital droplet PCR is a way of getting a more sensitive, specific, and repeatable test than reverse transcriptase quantitative PCR. So this looked at nasal swabs collected from between November and September of 2020 to 2021. Most of the people were unvaccinated, and then tried to outline, was there an association between amount of virus by digital droplet PCR and outcome? And the answer is yes. There is a correlation between the viral load and time to symptom onset. The higher the amount of virus, the faster the symptom onset. And there's also correlation between the amount of virus and the presence of GI symptoms, respiratory symptoms, fever, and headache. So let's take a look at another way of doing this. This is a more severe outcome than any of those symptoms. This is death. And in the univariate analysis, there is an association between viral load and death during the hospitalization. And that actually remained in a multivariable analysis. So I want to say that viral load is predictive of symptomatic disease, and it's predictive of in-hospital mortality. So what do we take home about this? There is this association between SARS-CoV-2 viral load and patient symptoms and outcome. And actually, I've reviewed several papers like this for clinical infectious diseases. It almost doesn't matter what technique you use to measure the amount of virus. The more virus there, the more bad it is. And the word worse is actually preferred over more bad or badder. So anyway, that's a joke. I just want to say that it's possible that in the future, if necessary, we'll have some sort of tool that measures the amount of virus in a more reproducible way than cycle threshold, which is currently what we use and is somewhat cumbersome and not reproducible. Okay, on to Nirmatrelvir plus ritonavir, aka Paxlovid. I'm just mentioning that brand name because everybody knows it by that, but I'm going to call it Nirmatrelvir plus ritonavir. And this is your old friend, the EPIC-HR study, making a comeback at IDWeek. It was, remember, a phase 2/3 a randomized, double-blind trial of Nirmatrelvir versus placebo in unvaccinated, high-risk people. It was a fairly large study with over 1,000 people per arm. They received the treatment within 5 days of symptom onset, and the primary endpoint was hospitalization or death, but there were also these other endpoints, and that's really the focus of this presentation at IDWeek, the other endpoints. And what they showed was that first, you already know the results for mortality and hospitalization because that was published in the New England Journal of Medicine. And that's what led to the emergency use authorization, that there was a significant reduction in death and hospitalization, despite these are unvaccinated people. So this is why so much Nirmatrelvir ritonavir is used. But new in this analysis are things like COVID-19 related medical visits. You notice these are also reduced. And then also there was a reduction in resource utilization, such as oxygen support requirement. And then there was another study, see this footnote 2, first author Hammond, that looked at symptom reported, and the treatment actually significantly reduced symptoms as well. So I'm going to just put my money down and say, if you have a high-risk patient, especially if they're unvaccinated, but even if they're vaccinated, one should lean towards treatment, despite the fact that you don't get 100% control of the virus in every patient. There are some people who have persistently positive or rebound viral loads in people who get treated with Nirmatrelvir ritonavir. But getting that antiviral therapy on board early does appear to prevent the most severe outcomes, which are things like hospitalization, death, and it hastens symptom recovery. And I got to tell you, my patients do say that going on this treatment does make them recover faster. No safety issues came up except for the well-described dysgeusia. Dysgeusia, that term has made a real comeback with COVID-19 and its treatment because taste disturbance, dysgeusia, is fairly common with this treatment. Just want to mention that it's almost certainly the ritonavir. Those of us who do HIV medicine remember ritonavir as a real cause of dysgeusia in some subset of patients. And the other thing is that patients who take this medicine, they tell you that they take the medicine and then they don't really get the dysgeusia until the absorption of the drug sometime later. So it's not something that happens at the time of swallowing the tablets. So take-home points from this study. Starting within 5 days of symptoms in this unvaccinated adult population who are high risk of progression, reduced COVID-19 hospitalizations, all-cause mortality, as well as healthcare utilization, and also reduced symptoms, shortening it by 2 to 3 days compared to placebo. That's a big deal in a respiratory virus, a very big deal. Okay, next study, Tixagevimab plus cilgavimab, otherwise known as, and I'm not supposed to use brand names, but I'm just going to say Evusheld, just so that you know what it is. This is the one that we have that's used for prevention, for pre-exposure prophylaxis, but this is a treatment study, and it's a treatment study called TACKLE, and it looked at non-hospitalized, unvaccinated adults over 18 with mild to moderate COVID, 903 in the study, randomized 1-to-1 to Tixagevimab versus placebo, with a primary endpoint of hospitalization or death, and then a secondary post-hoc analysis of self-reported COVID-19 symptoms, severity, symptom progression, and time to symptom resolution through day 29. Now, I should emphasize that this drug, this combination of monoclonal antibodies, is not approved in our country for treatment of COVID. It's only approved for pre-exposure prophylaxis, but there is some countries where it is approved for treatment. So let's look at the symptom progression. All right, Tixagevimab, symptom regression through day 29, 55.7% versus 63.4%, and that's statistically significant. So it did significantly reduce severity and accelerated symptom improvement through day 29 of treatment. That's a month or so. That's good news. And if you take a look over here, I mentioned symptom severity was improved. Here's the various symptoms showing their improvement over time and faster time to symptom resolution. There was no difference in fever duration. Now, I'm just going to say that I don't think that we're going to see Tixagevimab available as a treatment here in the United States, partially because the new variants that are emerging are unfortunately resistant to this. But nonetheless, the monoclonal antibodies, we have learned some things over the years from this. A single 600 milligram dose of this combination monoclonal antibody product does reduce the symptom severity and expedite symptom improvement in people at risk for severe disease. So it could help people get better faster. So I'm going to stop now and pass the baton on to my longtime friend and colleague, Dr. Princy Kumar. Take it away, Princy.
Thank you, Dr. Sachs. So I'm going to do the study that was presented by the Cleveland Clinic Department of Pharmacy. As we all know, we use Baricitinib or Tocilizumab in patients along with dexamethasone who have at risk for rapid progression. And we have not really, and Tocilizumab, many of our hospitals had problems getting Tocilizumab into the not into the formulary. There was such a demand for that. So what this group, and if you look at the NIH guidelines, they said we could use either one of the two. So in Cleveland Clinic, the Department of Pharmacy went back and did a retrospective chart review to see, is one better than the other? It had all the drawbacks of a retrospective study, but let me show you what they showed. So they looked at their site from July 2020 to December 2021, and they looked at, and their primary endpoint was in-hospital mortality, and their secondary endpoint was CRP levels, hospital or ICU stay, or respiratory-related readmissions. And this was overall the cohort, what they described was very similar between the two groups, where age, BMI, or comorbidities were concerned, but there were more women in the Toci group compared to the Baricitinib. Now let me tell you what the outcomes they showed. They said overall, there were more infectious disease complications in the Toci group compared to the Baricitinib group. And if you look down at the blood cultures that were positive, you can see the difference between the two groups and additional sources of infection. But what their primary outcome that I want to show you is that patients in the Toci group had an 86% higher odds of death compared to patients in the Baricitinib group. They did not specify what they died from, but they said that was their primary outcome. When they looked at their secondary outcomes, except for the CRP level that favored Toci, everything else favored Baricitinib, whether it was length of stay in the hospital, length of stay in the ICU, mechanical ventilation, and organ support. All of those things favored the Baricitinib group. What I viewed as some of the drawbacks of the study is they actually didn't tell what the dose of Toci is. The actual dose of Toci that you and I use for the adult population is 8 milligrams per kilogram, not to exceed 800 milligrams. But I know in my hospital, we started using lower dose when we before we felt very comfortable using Baricitinib, we used the lower dose. But they actually didn't tell the dose of Toci that they used. So I thought that was one of the things. The dose of Baricitinib, I'll just remind any of the younger learners here, that's like a fixed dose. If you have a normal creatinine, you can just use 4 milligrams once a day. Then we move on to the next study. So the take-home point, before I move on, is in hospitalized patients with COVID-19. This is during the Delta and the early Omicron wave. Those who received Baricitinib had a lower in-hospital mortality and better clinical outcomes compared to Toci when it came to lower mortality rate, shorter in-hospital stay, fewer requirements for mechanical ventilation and organ transplant. I'll again remind you it was a retrospective study with all the drawbacks of a retrospective study. But I went back and looked at the NIH guidelines last night, and they actually gave a better rating to Baricitinib than to Toci. So I thought that was good. So next, this study generated a lot of interest during the meeting. It was an inhaled interferon beta 1A, and this was called the Sprinter study. I think people so much want to have something for post-COVID syndrome. I think that's why it generated so much of study. But let me tell you what they presented. So this was a multinational, randomized, double-blinded. So remember, it was double-blinded, placebo-controlled trial in which adults who had COVID and needed oxygen, they were randomized to get either this inhaled interferon that they gave through a special nebulizer, interferon beta 1A, plus standard of care for 14 days versus placebo with standard of care for 14 days. The primary endpoint, which is time to hospital discharge and time to recovery, day 28, that was the primary outcome. The secondary endpoints was progression to severe disease or death within 35 days or progression to intubation or death within 35 days. And the third thing was long COVID outcome, which they analyzed in a post-hoc analysis. What they showed is a study did not meet the primary endpoints. And remember what I told you, the primary endpoints was time to hospital discharge or recovery. It didn't meet the primary endpoints. But I think the study still generated interest is because there was numerically reduced progression to severe disease or death in the group that got the inhaled interferon beta alpha. And you can take a look at the rates, but that's all I'll say here. And also of some interest, what generated interest is its effect on long COVID symptoms. And they looked at patients at day 60 and day 90, and it suggested a possible benefit. And the possible benefit was where fatigue and malaise was concerned, and where loss of smell and taste were concerned. And loss of smell and taste is very, very important to patients. I think that may be why it generated so much of interest. Also, there was decrease in the incidence of arthralgias, myalgias, and headache. However, there was no difference in this FACT-F, and that stands for functional assessment of, it's a whole, this thing that looks actually at fatigue. That's the main thing it looks at. So none of the other things had any change. So here's my take-home point. So the primary outcome it didn't meet, that was time to hospital discharge or recovery. But what it did do was there was some improvement in where there was less progression to severe disease or death in the group that got the inhaled interferon beta 1. And there may be beneficial effects in long COVID symptoms. So now let me show you the Tixagevimab and cilgavimab pre-exposure prophylaxis. As Dr. Sachs told us when he was doing his part, I call it Tixa and Cilga. Tixa and Cilga, as you know, has got EUA for pre-exposure prophylaxis. As Dr. Sachs told us, when he presented his data, he presented you the treatment data, but said multiple times what the FDA has given it for is this one, to give it for as pre-exposure prophylaxis for patients with immunosuppression. And the reason we give it is you and I know that though they get their vaccines, most of them do, they still don't respond. They don't have the immune response that you or I may have. So this is an added bolus of antibodies that we like to give our immunocompromised patients. And the way many of you do it in your centers, the way we do it is we always encourage vaccination. It's not a substitute for vaccination. And we come and we give them 2 injections at the same time, 1 injection of Tixa, 1 injection of Cilga in their buttocks, one after the other. We watch them for an hour, we let them go home. And then at the current time, the recommendation is to bring them in every 6 months and give it to them. Dr. Sachs already referred to the fact that we have some concern that some of the newer variants, especially B4.6, may not be protected adequately. What we want to show you in this is we have consistently said this is not a substitute for vaccination. We want our immunocompromised to be vaccinated, get all their boosters, and we want to give them Tixa and Cilga. So what I'm showing you right now is an observational analysis from the Minnesota Department of Health. Many of our departments and universities have been giving it. So they collected data through a voluntary registry of people who got Tixa and Cilga and looked at it to evaluate for vaccination status. Were these people vaccinated as they're supposed to? Breakthrough infections and hospitalizations. And they collected it from December of 2021 to June of 2022 for 6 months. And then they looked at all the things. I'll show you here the data. So overall, they collected data for 296 subjects. Out of this 209, remember, these are immunocompromised patients. If anybody needs to be vaccinated, it is them. Only 69% were fully vaccinated by the time they came to get the Tixa and the Cilga. And when we say fully vaccinated, we mean their primary series and at least 1 booster. So only 69% were fully vaccinated. you can feel sad looking at it, but when I show you the second set of data, you'll become even sadder. When they looked at the second time, remember they have to come back after 6 months. The second time they came back, all of them were actually eligible for their second booster. Out of them, only about 30% got their second booster by the time they came. So it goes to show you that people are not, even people, and that's been my experience, who are willing to go get their first booster. For much of America, the pandemic is behind them. And they haven't got, so only about 30% or only 30% had gotten their second booster. Now let's look at preliminary efficacy data in the small cohort. 5.7% had a breakthrough COVID infection. Out of this thing, 1.4% were hospitalized, and there were no COVID-related deaths. So the point that I really want to make to you, and what I like to tell my patients, that this is a supplement to and not a substitute for the COVID-19 vaccine. And whenever even we collect our data to see who comes down with COVID, what I always tell patients is the thing for vaccines, the thing for cilga and Tixa, it's not that it'll completely prevent you from getting COVID-19. What it does, it really reduces the severity of infection. It prevents them from being hospitalized. It prevents them from death. So now looking at fungal infections in solid organ transplant recipients with COVID-19, this data was actually presented by the Jackson Memorial Hospital, that's part of the University of Miami. And we have all seen an uptick in COVID-19 associated fungal infections in our solid organ transplant patients. So this center, Jackson Memorial, it was a retrospective study. They said, let us characterize our COVID-19 associated fungal infections in a solid organ transplant. And they looked at it from March of 2020 to January of 2022, and there are 23 infections. They removed all the Candida infections. They didn't include the Candida infections. So overall, 3.8% of the solid organ transplant patients who had COVID came down with a fungal infection. So that's 3.8%. So that was 23. Most of it was a kidney transplant patient. You can see 86.9% was a kidney transplant patient. I'll highlight the points that I think are very relevant. 95% of them needed admission to the ICU, and that has been our experiences also. And then if you look here, to me, look at the thing marked in red, which is what we have seen also, the high mortality rate. So even though the number was low, only 3.9% of the patients with COVID got invasive fungal infection. But once they get it, their mortality is really horrible, 73.9%. So that's the point I want. They went on to say that the median time from COVID diagnosis to fungal infection was 21 days. Most of the patients were not on antifungal prophylaxis because most of them didn't need it because they were months and months after transplant. And then the vast majority of the infection was aspergillus. About 70% was aspergillus and about 4.3% was mucor. And as I told you, the others was a splatter that they didn't include the Candida infections. So here my take-home points is Tixa and cilga as pre-exposure prophylaxis is beneficial but not a substitute for COVID infection. And for us, really the impact that once they have COVID and if they develop fungal infection, the high mortality that is seen in these patients. This is my final slide. I'll go through it quickly. This is from Finland, the solitary Finland trial. Basically, what this trial did was the effect of remdesivir on post-COVID. That was what this whole thing was. So this was an open label randomized. So it's open label. It's randomized. It was multi-center trial from 11 hospitals. And they took patients and they either got standard of care with remdesivir or standard of care alone. And basically what they wanted to look at is not what happened to them during that hospitalization, what happened to them 1 hour post-hospitalization. But not 1 hour, 1 year post-hospitalization. That's why we included it, because we really don't have data, good data on a year after what are people doing. So the primary endpoint was self-reported recovery, exertional dyspnea, fatigue, and quality of life. And the secondary endpoint was mortality and long COVID symptom. And what it showed is that there was no difference actually between the two groups. And the people who got remdesivir and the people who did not get remdesivir, at the end of 1 year, there's really no major differences in the two groups for the 21 potential long COVID symptoms. But the reason we agreed, first and foremost, it was a one study that was 1 year later. But I like to point this out is that we still don't know what to do with this group of people. We send them to a multidisciplinary group. And I just want to remind you again that 1 in 6 survivors report that they have not fully recovered from COVID-19, and 1 in 4 survivors report ongoing substantial fatigue. So there's still a lot of work that we all have to come together to do in caring for these patients. With this, we are going to open our question and answer session. So some people have put some questions in the chat. I'll take the first question and then I'll give it to the next to Dr. Sachs. I think there's a question asked about relapse after COVID and how many days is it typical for the antigen to remain positive. So from everything that I know, and I like Dr. Sachs to come, once they have this rebound phenomenon and their antigen test positive, the antigen can stay positive for up to 7 days. So the fact that your patient was positive for 5 days, strongly positive, is not unusual. Usually, when I look at it, and I like Dr. Sachs to comment on it, is they can remain antigen positive for at least 7 days. And that's why we tell them that they need to sadly wear their mask again and consider them contagious. The question always has been, is should they be treated? It's an open question. I don't normally treat them if they have mild symptoms. I just am kind to them on the phone and make them stay home. Dr. Sachs, do you want to comment on that, please?
I would agree that the relapsers, rebounders, whatever you want to call them, are often positive for at least 5 days. 7 to 10 days for clearance would be typical. And just a reminder that this testing is actually not required. And some people just go on the, after 10 days, if I'm improved clinically, then I don't want to test, then I'm ready to go back to the world. There is pretty decent evidence that some fraction of the people, Paxlovid or not, are going to still be contagious at day 10, but we'll see. Next question is, I heard from patients and healthcare providers that because we don't have human data on the bivalent boosters currently in use, they don't feel comfortable receiving or recommending it. How do you approach this discussion? Well, we're starting to see some data on safety in preprints, but we don't have efficacy data yet. That's true. The case I make is that the technology is exactly the same as the previous vaccines, and the only thing that's different is the insert, and that it convinces some of them. But I would say that if you wanted to really push someone right now, it would be to get that third vaccine, especially your older patients. That would be that would be where I'd focus my attention. Princy, you want to take the next?
So the question is, for Evishield, would you consider using it as a therapy on the future rather than pre-exposure prophylaxis? I think the whole thing is going to depend on what the variants are going to do. As I said, the B4.6 variant that has come along happily and slowly going up, Evishield has no activity for that variant. So it really depends upon the variants. And for me, I'm thinking right now, we have bivalent right now. So far, it appears effective for the variants. So I would rather use bivalent for my treatment if I have to use a monoclonal antibody, and keep Evishield for my pre-exposure prophylaxis.
It's really quite something. We have this whack-a-mole situation with the monoclonal antibodies, all these antibodies that we've kind of memorized that are no longer in use. And at least based on the last variant call, we are down to 87% susceptible for bebtelovimab and heading south fast, unfortunately, and only 60% susceptible to Tixagevimab, and that is also heading south fast. So I have a feeling that if we were to come back in a month and give the next COVID-19 webinar update, that we would be talking about monoclonal antibodies that are no longer active, alas.
If I could add to that, Dr. Sachs, so far the antivirals have retained the activity for these variants. I think that's very important for us to convey to our patients, anybody who's willing to listen to us right now, that Nirmatrelvir, ritonavir, molnupiravir all have retained, and remdesivir for that has retained the activity.
So there's one last question, and then we'll wrap up. It says, can I speak about using Paxlovid on inpatients? So it's not that Paxlovid use on inpatients is prohibited. It's that it's not indicated or not approved for treatment of people hospitalized for COVID-19. So what that means is that if you have someone who's hospitalized for other reasons and you want to treat them with Nirmatrelvir, ritonavir, you can. However, in the hospital, our go-to has been remdesivir because it is FDA approved, and we typically use that. I will mention some clinical trials on Nirmatrelvir that are ongoing. One is testing 5 versus 10 days of treatment in people who are immunocompromised or at otherwise high risk. And the other is a study of retreatment versus no retreatment in people who have rebound. My own feeling about these studies is that it's about time because we've known about this rebound phenomenon for months and months and months, and COVID is very common still. So it does surprise me that we don't have any actual data on what to do. So I have heard anecdotes that in countries where you can treat for longer than 5 days, they're not seeing rebounds, but I actually can't speak to any science on that.
Thank you for taking time to spend these 45 minutes with us. Thank you.
Thanks so much.
Thank you very much to Dr. Kumar and Dr. Sachs, and thank you to our listeners for joining in. As a reminder, to view the full IDWeek 2022 COVID-19 conference coverage program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.